So we're now moving to the next part of our program. I would like to introduce our subject matter experts. You know them all, John Szumowski and Emma Bainbridge.
So thank you for having me. I'm Emma Bainbridge, for those of you who haven't seen me speak before. We're doing something a little bit different for this session. The past couple of sessions we've had patient cases, but I thought today it would be a good opportunity to bring it back to the basics and really talk about the clinical importance of viral loads so that we have some context for everything we've discussed today in terms of the importance of viral loads and why viral loads are such an important metric for us. So we are going to talk a little bit about HIV natural history and viral dynamics. We're also going to define types of virologic response and discuss their clinical significance. And then we're going to summarize how resistance develops when patients experience virologic failure. So starting from the beginning, this may be a graphic that many of you are familiar with, but just to return to the basic biology of HIV a little bit, viral dynamics are important. They help us predict what HIV infection is going to do in the absence of ART, and they also help us predict what will happen when you start ART and how that will affect your plasma viral levels or your viral load. So looking at this graph on the right here, just to orient everyone, the blue is CD4 counts and the red is viral loads. And you're looking at the trends over time, starting with the first few weeks of infection and extending into many years after you've been infected. And so this is the natural history of HIV, assuming you don't start any medication. So after your initial infection, you see an exponential increase in viral load that occurs. And this is because HIV virions are infecting your lymphocytes. There's rapid turnover of those cells with a lot of HIV replication, and all of that HIV is being released into your bloodstream and then infecting even more cells, and the cycle continues. And so in that acute phase, your viral load may reach millions of copies per milliliter. And then over time, as your immune system kind of catches up to what's happening and starts targeting those virions and those infected cells, your viral load declines, and it will stabilize to a viral set point, usually within the first 3 months of infection. I have seen viral load average estimates of viral load set point estimates that are like in the 30 to 50,000 range, but it can be a wider range than that, anywhere between 1,000 and 1,000,000. And it varies by patient. And it's important to know that if you start with a higher viral set point, that often suggests a more rapid progression to AIDS, unfortunately. And so usually patients will remain stable at a certain viral set point for many years. And then on average, you progress to AIDS around a decade after your infection. And that's when you'll see your viral load start to rise again while your CD4 count is declining. And then I just wanted to introduce this concept of the founder virus, which I think is helpful for understanding, where resistance comes from. And so there's a nice picture here that explains what happens. So essentially the idea is that in an established HIV infection, you have a diverse viral population. So you have many different HIV variants or quasi-species that happen from just mutations over time in such a big population of virus. But when you have a new infection, there's one dominant virus that is responsible for that new infection. So 80% of sexually transmitted HIV infections are established by one single variant. And it's usually the one with the highest viral fitness, the one that's most able to replicate and become dominant in a population, which tends to be a CCR5 tropic variant. And so that's the variant that's going to proliferate the most in those early stages of infection. But it's important to remember, and we've talked about this before, that the process of HIV replication is error prone. HIV does not have all of the mechanisms that we have as humans to fix their genetic code. And so inevitably mutations get introduced, and then that diversifies the viral population. And so why do we care about that? This is basically a picture of the same thing that I just described. It's a little bit prettier than the prior slide. But the reason it's important is those minority populations eventually can give rise to antiretroviral resistance, especially in the setting of inadequate suppression or inadherence of an ART regimen. And the other thing that's important here is that if you are capable of getting an HIV genotype, those minority populations may not actually be captured unless they are a decent proportion of the total viral population. So you may not see that those are there because they're kind of hiding in the background. So we've talked a little bit about the natural history of HIV, and now I want to talk about what happens if you start ART. And so we'll talk a little bit about HIV viral decay, which is essentially a predictable pattern of virologic response that we see with mathematical modeling that happens after you start ART. And this is helpful because it gives us some context for how long we expect it to take before patients suppress on ART. It's a wide range, but we do expect for patients to suppress within between 8 and 24 weeks, assuming they're taking their medications regularly and that they are susceptible to the drugs that they're receiving. If you start with a higher viral load, it does, not surprisingly, take longer to usually achieve suppression. So going into what this really means in terms of using the graph over here on the right to help us understand, there are 3 phases of viral decay. And I think I want to just focus on the first phase because I think that's the most helpful for us in terms of clinical management. So in the first phase of viral decay, your viral load is expected to decrease 100-fold. That's also sometimes called a 2-log decline in the first 2 weeks of being on ART. And this actually happens even faster with more potent ART regimens. So in particular with integrase inhibitors, we expect that 2-log decline to occur maybe even in 1 week. And what's happening here is all of those T cells that are infected and rapidly turn over and release new HIV virions into the bloodstream, those are the ones that are being targeted by your ART. And so by kind of removing those cells, the HIV viral load is going to rapidly decline. In the second and third phases, though, the rate of decline is much slower, and it's because the ART at that point is targeting the infected cells that tend to have a longer half-life. Those other cells in the viral reservoir that are sort of harder to get to, the latently infected ones, et cetera. And so it's a little bit harder to anticipate what happens with your viral load in those second and third phases. But for the most part, patients should achieve viral suppression during that second phase of decay. But really, I just want to highlight that in the first phase of decay, it's pretty consistent across the board. You should expect a 2-log decline in your viral load within 2 weeks, if not sooner, on INSTI-based regimens. Shifting gears a little bit, I want to talk about viral load terminology so that we're all sort of on the same page. I think this can be challenging because there are different definitions used in different contexts, and also in prior HIV literature, like if you read the literature from the 90s and the early 2000s, the definitions are not entirely the same, but I think it's still helpful. So going from left to right here, starting with virologic suppression, I have a written definition and also a graphical representation of this just to kind of get a sense of how this looks if you're trending out your viral loads. Virologic suppression is a viral load below the lower level of detection of the available assay. I think that's probably a concept that everyone is familiar with. The assays, they can vary. So it's between, if you're using a high sensitivity one, between 20 and 50 copies per milliliter. And I know in the Philippines treatment guidelines, virologic suppression, they have a cutoff of less than 50. But again, I recognize that it kind of depends on what assays you have available to you. And then in the middle here, we have a picture of a virologic blip. And what that is a single detectable viral load that then returns to virologic suppression. So you're suppressed, you have one viral load above the threshold for suppression, and then you go back down. And I think typically we use a cutoff of, virologic blips should be less than 200 copies per milliliter, but there are inconsistent definitions out there, especially in the older literature. A blip might be allowed to be as high as 500 or even upwards of 1,000. But we'll talk a little bit about why that might not be the same sort of pathophysiology. And then low-level viremia is here on the right. So that's a persistent HIV viral load above the level of detection, but below 200. And again, in the past, low-level viremia had some different definitions. So prior literature had it, was a little bit more permissive for how high your viral load could be. And essentially low-level viremia is if you have a blip and then it continues to be above, once you have, you don't have 2 blips in a row, that becomes low-level viremia. And then in contrast, we have virologic failure, which is inability to maintain a viral load less than 200 copies per milliliter. And there are kind of 2 flavors here. So virologic rebound refers to someone who achieved virologic suppression and then their viral load went up above 200, whereas incomplete virologic response is the scenario where you've never achieved suppression even after 24 or more weeks on ART. And to get into a little bit about why this all matters, we'll start with virologic blips and just talk about the clinical significance. So the idea is that blips are probably related to release of virus from latently infected cells. And so that's not the same pathophysiology as when you see uncontrolled viral replication in, an acutely infected individual or someone who has recently stopped taking their ART. This is usually kind of less clinically worrisome or significant. And so past data has shown that isolated blips do not usually lead to development of drug resistance or virologic failure. I found an old study that looked at over 3,000 participants, and they found that blips greater than 500 copies per milliliter was associated with an increased risk of virologic rebound. That said, 500 copies, I think, is a very different sort of clinical scenario than someone who has a viral load that's, 100. I think in that scenario, I'm more concerned about something like inadherence or another reason that they have subtherapeutic drug levels. And so because typically blips are not associated with the development of drug resistance or virologic failure, that also means you don't necessarily need to change their ART. So that's not recommended for an isolated blip. You should, however, assess other reasons that they might have a rise in their viral load, things like inadherence, new medications causing drug-drug interactions, factors that might affect GI absorption or acute illnesses. And then again, it's important to remember that blips can be the stepping stone to low-level viremia or even virologic failure. And so having a follow-up viral load to ensure that you go back down to being suppressed is really essential, because you can't call it a blip until you have that follow-up viral load that is back to being suppressed. If, however, your next viral load is not suppressed and it continues to be above our threshold, then that is when we start labeling things as low-level viremia. And looking at prior cohort studies, up to 4 to 8% of all patients will develop low-level viremia after their initial suppression. This is more common with a few different factors. So having a high pre-treatment viral load sort of predicts low-level viremia occurring later on. And that's probably because that high pre-treatment viral load is indicative of a larger HIV reservoir. A history of advanced HIV is also associated. And then there have been studies that show there's an association with PI-based regimens, although there may be some confounding here because, people are often put on PI-based regimens because they have issues with inadherence. And so providers choose to put them on regimens with a high barrier to resistance. And so low-level viremia in that setting may be more related to inadherence than the PI regimen itself. And so again, there are a lot of different reasons that this may happen, which we sort of talked about on the last slide. There's also this idea that there may be clonal expansion of HIV in the clonal expansion in the viral reservoir, which is sort of beyond the scope of this and more on the science side of things and helpful for, thinking about HIV cure, but probably doesn't have a lot of clinical relevance for this. And then in terms of the actual significance of patients having low-level viremia, this is a challenging question. There's a lot of conflicting data around risk of virologic failure and developing resistance. There are some studies that suggest low-level viremia is very concerning, and then there are other studies where that doesn't really pan out. I will say that many of the studies are done, they're observational cohort studies, and they tend to be older studies, and they use very inconsistent definitions of low-level viremia and virologic failure. So some of the studies that found a relationship between low-level viremia and virologic failure, when you look at how they define low-level viremia, it's a much wider definition. And so a lot of the patients that did develop failure were the ones that their quote unquote low level viremia was like 500 or almost 1,000, not between 50 and 200. What we do know, though, is that low level viremia does not increase the risk of HIV transmission. And the reason we know that is that, the studies that support this concept of undetectable equals untransmittable, or U equals U, their suppression cutoffs were much higher than the definitions that I just provided to you. So there were two studies, the partner study and the opposites attract study, that used a viral load of 200 for viral suppression. And then there was another one, the HPTN 052 study, that used 400. And in those studies, the patients were considered suppressed and they did not transmit HIV to sexual partners. So that's very reassuring to us. So overall, in the US guidelines, we do not recommend changing ART when a patient has low-level viremia. That has been studied, and they have also looked at intensifying the ART regimen, so adding an additional agent, and that was not beneficial. So essentially, the recommendations are continue the current ART and then assess for all the factors that we've previously talked about that may affect a patient's virologic suppression. And then finally, moving on to virologic failure, I just want to spend a minute talking about how having a viral load above 200 provides the opportunity to develop resistance. And so we'll use this graphic here on the right to kind of walk through that. So there are a lot of reasons that patients may have incomplete suppression, low potency ART, low drug levels for various reasons. Absorption might be one of them, drug interactions, inadherence, etc. And what happens in that situation is you essentially select for the HIV mutants that are in your population of HIV that are resistant to the current ART regimen. You can also develop de novo mutations that result in resistance. So walking through this graphic here on the right, on the first square, that is your population of HIV in a pre-treatment individual. And so most of those virions are going to be wild type HIV, and that's because wild type HIV has the best fitness, meaning that it's like the most able to replicate and becomes the most prevalent. You may have a few mutants in there that are still able to thrive and replicate. The yellow one and the pink one are the mutants there that have some resistance mutations, but they're all still relatively fit, so they kind of continue to replicate. Once you start ART therapy, ART, then you are essentially eradicating most of those virions. And so there aren't many of them still replicating, but you may still have, HIV virus in latently infected cells, and they're kind of hiding out. And so then when you develop adherence problems, the remaining HIV starts to replicate again. And the mutants or the HIV quasi-species that tend to thrive are the ones that can overcome the resistance barrier of the ART that you've put them on. And so that is represented here by the pink and the yellow and the blue little dots. So two of those, the pink and the yellow, they were there before and they've just been sort of hiding out. They were already part of your viral population. And then the blue represents potentially de novo mutations that allow that specific quasi-species to thrive in the setting of, of incomplete suppression. And then as you continue to have adherence problems, the viral population gets bigger and bigger. And again, you're mainly seeing resistant HIV and not the wild type HIV. And then once you're completely off ART therapy, so you completely stop taking it, the wild type virus tends to come back as the most prominent virus because it does have the best fitness, and those mutations have a fitness cost for the virus. So in the absence of ART, you see the wild type virus, but it doesn't mean those resistant strains are gone. It just means they're kind of hiding away. They may be in latently infected cells, and you may not see them until you select for them, meaning you have the selective pressure of ART that they don't necessarily respond to. So what does this mean? Essentially, it means that if your viral load is greater than 200, you're going to see some viral evolution, and there's a good chance that you'll develop emergent resistance. And this has been seen in prior studies, in particular in studies where your viral load is less than 1,000. So not particularly high, but still provides enough of a kind of selective pressure that emergent drug resistance will occur. And they've seen it actually as low as, in the 200 to 500 copies range, you can see new resistance mutations develop. And what's particularly challenging is that in patients that are drug experienced and they're on salvage regimens already, they can develop mutations at even lower viral loads than naive patients. And that poses a challenge because those are patients that already have limited options available to them. So what should you do in these scenarios? In the ideal world, you obtain drug resistance testing while your patient has that selective pressure of the ART regimen on board. But if you can't get a genotype, you should attempt to empirically construct a new regimen based on what you know about the patient and their virus. So things like their treatment history and their adherence issues, and also the drugs you have available, the resistance barriers of those drugs, et cetera. Ideally, you switch your regimen as soon as possible because that removes that selective pressure that allows drug resistance to develop. And the other thing that's important to consider here is that you're more likely to achieve virologic suppression if you start from a good place. So if you have a lower viral load and a higher CD4 count at the time that you change your regimen, you're much more likely to achieve suppression than if you wait until they have uncontrolled viremia and a low CD4 count. So just to put this into context, the reason we care so much about viral load monitoring is it really helps us make sure that we control the HIV in patients that we already have, and we prevent incident infections. So just going back to the concepts I mentioned earlier, if you know the sort of viral decay expectations for a patient's virus, it will help you anticipate what their viral load should do after you've started ART. So you may not even have to get a viral load after a couple weeks to really see that, but I guess the opposite scenario would be if you start someone on ART and their viral load is 100,000, you would expect their viral load to drop to 2 logs, right? So down to 1,000 within a few weeks. So if 3 months after you start ART, their viral load is still 50,000, that suggests that there's an issue. Either they're not taking their ART, or they have some resistance that we haven't sorted out, or there's some other issue that regimen is not working for them because you're not seeing the viral decay that's expected. Regular monitoring of viral loads also allows us to ensure that patients do not develop low-level viremia or virologic failure. But if you do identify those things, then that prompts you to switch their ART as soon as possible to prevent additional resistance from developing. And then similarly, once you switch their regimen, if you don't have a genotype to help guide you, confirming that they have appropriate virologic response is a really helpful way to make sure that you've selected an appropriate second-line regimen. And then finally, just going back to the concept of U equals U, having viral loads on our existing HIV patients allows us to prevent incident infections from occurring in sexual partners who are at risk. So I'll stop there. That's the end of my talk. And I'm not sure if we're going on to questions or if we're moving on to the next session, because I know we've been skipping Q&As.